Hello, I'm Amy Caples, Assistant Professor of Media Studies and Production at Temple University, and I'd like to welcome you to the result of a very unique partnership with Temple University's School of Pharmacy and the Institute for Safe Medication Practices, better known to you as ISMP. As you may know, ISMP is the nation's only nonprofit organization devoted entirely to preventing medication errors. In this exciting new video newsletter series, we're going to provide you with updates 4 times a year on the most urgent safety matters in the healthcare industries and bring you recommendations from some of the leading experts in patient safety issues across the country. I will serve as your guide along the way, and we'll learn a lot together. So let's get started. We're going to begin this series with a topic that's considered an essential part of healthcare delivery: IV push medication use. More than 90% of hospitalized patients receive some form of intravenous or IV therapy. But while the administration of medications by the IV push route has become a routine part of patient care, the lack of generally accepted safety standards for IV push medication use contributes to the potential for patient harm. Variation in practices related to preparation, labeling, and clinician administration of IV push medications hold the greatest cause for concern, but also the most significant opportunities for safety improvements. With us now is registered nurse and vice president of ISMP, Susan Paparella, who will share with us some of the key findings and recommendations from ISMP's recent national summit examining IV push medication safety practices. Susan, welcome and thanks for joining us.
Thank you, Amy.
So first of all, let's talk about, with so many types of medication errors that occur, why is Summit to focus just on the safety of IV push medication use?
So in the hospital setting, medications are commonly administered by the IV push route. And studies have shown us that by this route, there's error rates are as high as 73%. So it's very concerning to us. And we know there's system issues that contribute to this, such as how drugs are, concentrations are manufactured, how they're packaged and labeled, and the availability of ready-to-administer products.
Okay. Now, reading the best practice statements from the summit, it sounds as if practitioners perform a significant amount of dilution of injectable medications prior to administration. Why is this problematic?
Well, there are legitimate reasons why medications are diluted before administration, but what concerned us was the seemingly routine and sometimes unnecessary dilution of medications at the bedside. And we saw risky practices such as syringe to syringe transfer of medications, the use of commercially available products as a vial, and the use of flush syringes, sodium chloride flush syringes, to either dilute and then administer medications.
Well, you mentioned the use of a pre-filled syringe of sodium chloride flush, for example. Can you explain why this may not be the best choice for drug reconstitution or dilution during preparation and administration?
Right. So the FDA has approved these as a device. They are actually never been tested or approved for the use of medication dilution or administration. And there's manufacturers are aware of that and actually have taken the gradations off the syringe, so it makes it difficult to measure a medication. And also they've put warnings on it that say for push only. So we want to make sure that practitioners aren't using these to dilute and reconstitute medications.
I understand that there is an entire set of IV push medication safety guidelines posted on the ISMP website that outline 29 best practices. Would you say that these guidelines are directed at nursing professionals?
Certainly nurses are the ones that give the bulk of IV push medications. However, there's a lot of practitioner types, physicians, anesthesia providers, medical technicians in procedural areas that also do IV push medication use. So we would say these are for all types of practitioners. And we would hope people would go to our website and download these and use them as they develop their best practices. And they can be found on the ISMP site, as you said, at www.ismp.org.
Susan Paparella, we thank you so much for your insight. We appreciate it.
Thank you.
Now we'll turn our attention to a rather heartbreaking story that has highlighted problems that exist with drug labeling. The death of a 16-year-old boy in an emergency room by accidental epinephrine overdose caused a stir in the medical community. After studying this and other cases, ISMP determined there are many issues with labeling epinephrine that require immediate attention. beginning with the confusing nature of dose concentrations that used ratio expressions, such as 1 to 1,000 and 1 to 10,000. Recently, the United States Pharmacopeia eliminated these ratio expressions on certain epinephrine injection labels. And as of May 1st, ratio expressions will no longer be allowed on labeling of single-entity drug substances. Joining me now is Mike Cohen, the president of ISMP, and a man well known for his work in patient safety and his dedication to understanding the causes of medication errors in the healthcare community. Mike practiced as a hospital pharmacist for more than 25 years before founding ISMP. Mike, welcome.
Thanks, Amy. Great to be here.
All right, Mike. ISMP petitions United States Pharmacopeia to eliminate ratio expressions on drug labels, and it seems like they've heard you loud and clear. Why was that done?
Well, we've had some very serious errors. The ratio expression is a way to indicate the concentration of a drug, and unfortunately, a lot of people aren't familiar with it. It's been around for a long time. As a matter of fact, it's an old-fashioned way to express the concentration of a drug. And it really requires, in dosing a patient, you need to do two things. You need to know what that concentration means, and you also need to know the volume. And mostly for most of the medications that we use the metric system, and doses are measured in milligram, and that's what's on the label. And people don't get confused by that pretty much, so it's a real problem.
Okay. How do errors happen with ratio expressions, and what happens to patients if a mix-up does occur?
Well, we've had some very, very serious incidents. As a matter of fact, what got us started with this petition to the USP to get the labeling changed to eliminate the ratio expression, we had a 16-year-old child that we learned about that came into an emergency room with priapism and unfortunately received a massive overdose of the drug epinephrine that's used for that particular condition because someone did confuse the ratio expression. Errors happen because people aren't familiar with it. They just don't know what it means. There's actually studies that show that doctors don't know what it means, nurses don't know what it means. And unfortunately, in making calculations to convert to the metric system, milligram dosing, for example, mistakes are made. So it is really a problem.
Now that we know the labeling becomes official on May 1st, which is good news, how will products be labeled going forward, and do you expect any issues during the switchover period?
Well, the USP and FDA has to follow what the USP indicates in the United States Pharmacopeia itself. We'll change the labeling of all the products so that it only expresses the strength in milligram, and the dosing will be in milligram or metric system. And the ratio expressions will be totally eliminated for the drugs that still exist that have that labeling.
Okay. Do you anticipate any problems with the switchover?
Well, we're a little bit worried that people are still used to prescribing using the ratio system, and it may, now that it won't be on the label anymore, unfortunately, some people might make the mistake in doing calculations and trying to convert from the way it was ordered into the metric system. So we're a little bit worried about that. There are several drugs that are still out there. For example, epinephrine is one that still has labeling with the ratio system. Isoproterenol is another one, and then neostigmine is another one. So you'll still see those on labeling today.
Okay, when will we see, or will we see, complete elimination of ratio expressions across all products?
Right, this is a good question. We actually will see this beginning May 1st. I think some of the companies are already gearing up and they're already designing new graphics, et cetera. It's going to take some time to convert it, and there's still a lot of old inventory that's out there. So during this transition period, I'm afraid we're a little bit worried about it. So that's why it's important for everyone to know about this conversion and to start educating staff and showing the new labeling as it comes in, for example. And doctors have to stop writing in a ratio. And I think most of them already do that, but unfortunately there's some holdouts. We just recently had a 38-year-old that unfortunately suffered a fatal event. He was moving furniture, he twisted his back, he had a back injury, came in for surgery, and unfortunately this type of mix-up did happen. They gave him a 10-fold overdose of the drug, and it was fatal.
Something we will absolutely be following. Mike Cohen, thank you so much, President of ISMP. Thank you so much for the information today.
Thank you.
All right, and finally, we're going to take a closer look at ISMP's recent efforts to create targeted medication safety best practices, which encourage all hospitals to implement uniform safety recommendations. ISMP has developed targeted medication safety best practices for hospitals. These best practices aim to identify, inspire, and mobilize national adoption of best practices on specific safety issues that cause fatal and harmful errors in patients. These errors continue to occur despite repeated warnings in ISMP publications. These best practices are realistic, to the point, and easy to implement. Joining us now is pharmacist Darrell Rich, who is a medication safety specialist for ISMP. He coordinates the Best Practice Initiative and is the administrative coordinator of ISMP's Medication Safety Officers Society. Darrell is here to explain some of these best practices that hospitals can focus their safety efforts on over the next 2 years. Darrell, welcome. Thanks for being here.
Great to be here.
All right, well, tell us first, when and why did ISMP develop the targeted medication safety best practices?
Well, we started this project back in 2014, and we did it because we were seeing over the last 10 to 20 years the same serious and harmful medication errors being repeated over and over again. So we felt we really needed to focus on these.
And are these best practices limited to just hospitals?
Right now they are, but they are applicable to other settings as well, such as ambulatory and so forth.
Let's talk about the recommendations. What were some of the best practices from the 2014-2015 recommendations?
Well, one of them was to put vincristine in a mini bag. Another one had to do with eliminating glacial acetic acid from all storage areas in the hospital. Using oral liquid dosing devices that only use the metric system, and then finally dispensing liquids in unit dose or oral syringes rather than bulk containers.
And how well implemented were those recommendations?
Actually, for the most part, very well. 75% or greater for most of those, some reaching as high as 90%.
So were any of those 2014-2015 best practices revised at all?
Yes, there were actually two of them where the compliance wasn't as good, and we found out some of the reasons why. So one of them had to do with oral methotrexate. We were finding that we were requiring a computerized hard stop verification, and many people's computer system couldn't do that. So we gave people an alternative to that. And the other one had to do with weighing patients in the metric system only and documenting it in metric system only. And one of the things we found that is kind of buried in the latter part of that guideline was that you actually weigh the patient and not just ask them what their weight was. So we really wanted to focus on that, and so we revised it to do that.
Okay, so moving forward to present day, what are the new best practices for 2016-2017?
Well, one of them has to do with sequestering, segregating, and differentiating neuromuscular blockade agents everywhere throughout the hospital. Another one has to do with using smart pumps for all high alert medications. We find that they're not used in every setting, such as ambulatory or radiology, as well as the fact that using it for all kinds of things like PCA and other areas. So we wanted to make sure that people did that, make sure the software was up to date. Another one has to do with having rescue agents available, such as epinephrine, methylene blue, if you're using benzocaine spray. We were finding that people either didn't have the products where they were needed, they didn't have orders, so they were waiting for a physician to call in an order, or they didn't know how to make it. They didn't have instructions readily available. A fourth one that we did was to eliminate 1 liter bags of sterile water throughout the hospital. This was often confused and hung on patients in place of D5 or normal saline, and that caused severe reactions in patients. Oh, then finally we had one having to do with using sterile compounding, making sure you don't use proxy methods such as the syringe pullback, and that you use technology such as barcodes and IV workflow software.
Obviously a ton of information. So where can people learn more about the new best practices?
Well, the best practices are on the ISMP website, www.ismp.org.
All right. Well, Darrell, thank you very much for this very important information today.
Thank you.
All right. That's going to wrap up our first edition of the ISMP video newsletter. As always, you can look forward to receiving your regular ISMP newsletter every 2 weeks. In the meantime, we'll be working to compile the latest safety information to bring to you in our next video installment. You can also get more information on the topics we talked about today and any of the latest medication safety news by visiting ismp.org. I'm Amy Caples. See you next time.